right. So which case is this? Oh, let me pull up the picture for this. Not a chest case in its true sense, but involving the chest wall. So this is just one of the larger tumors of the chest wall I've seen, and I figured, see if I can show this. So this is what it looked like on, I guess, visual inspection. And this is what it looked like on the CT, quite a large tumor, very, very vascular. And this was a malignant phyllodes tumor. And, you know, this is just one of those. And one of my colleagues told me that these can grow quite rapidly. But again, you just wonder at what point you decide to come and see and get medical help, given the size of these things. So anyways, just a really impressive, and I never realized how vascular these lesions were, these phyllodes tumors, but you can see how avidly enhancing it is. And these massive vessels just going throughout in this big area of necrosis. So I thought that was an impressive case. This is something, this is something that was very odd. So this is a patient who had a history of breast implantation, I think a redo breast implantation, and then underwent a one of those sympathetic ganglion, I can't remember, like we have sweaty palms or something, and they go in your axilla and they kind of ligate one of the nerves that supposedly causes you to have sweaty palms. I'm not really sure. But anyways, when they did that, supposedly she woke up in a in the ICU she went in for this kind of basic surgery, woke up in the ICU. That's why she got the second breast implant, because I guess the first breast implant was gone, and she got a second breast implant because the first one she never really knew. They kind of told her, oh, there was something happened. And anyways, you can see that there's this strange stuff along the fissures. So what happened is they actually somehow, going in through the axilla, I don't even understand how it happened, but they somehow ligated or got into the breast implant and created some sort of communication between the breast implant and the pleural space, and the silicone from the prior breast implant just leaked into the pleural space. And you're wound up with all of these basically silicone globules studding the fissures. It's almost like a pleurodesis, but all these silicone globules studding the fissure. And silicone, for some reason, just winds up developing a lot of this calcification. But this is intrapleural silicone secondary to some surgical manipulation and breast implant injury. I don't know if other people have seen that before. That was a new one.
That's insane.
Never seen that before. Never see it again.
So they're going to take her. She's asymptomatic, but they're going to take her to surgery because she wants it out of her, is what she's telling them. And our surgeons, of course, like many surgeons, are more than happy to oblige. So I said, please take pictures of the surgery and the specimens. I don't think, I mean, this stuff's got to be matted down, but they're going to do more harm than good. But
Seth, was the original implant cosmetic or because of breast cancer surgery?
No, cosmetic. She completely had cosmetic implants. And I think they're both like the right implant. And she went in again for this thing where they go in the axilla. It's like one of these day surgeries. You get it snipped to get a fortune out of it. And somehow she had no history of malignancy. And this was the replacement implant after she woke up in the ICU with a completely deflated chest. And she went in, and the history is that then she had to go to a plastic surgeon. The plastic surgeon says something like it was a complete mess in there. The breast implant that was in there before had been just completely popped. There was silicone everywhere, throughout the chest wall, throughout the pecs, everywhere. They basically got to scoop it all out. And some of it, I guess, either presumably from the initial surgery, but potentially even from the reconstruction could have leaked into the pleural space, but I'm not sure where it occurred.
We should call this an augmentation pleuroplasty.
Yes. And then I think Jeff showed a case similar to this. What was striking to me is the nodularity with this is really striking. I mean, at least for a case of what this is. I mean, I think people can see there are what appear to be small nodules in the lungs. And let me see the lateral. If I have a lateral here, somewhere in here I have a lateral. But his PA doesn't look that big, but I can tell you he has very severe pulmonary hypertension. He was coming here for a potential endarterectomy, and you can see his VQ scan actually doesn't show much. Some kind of hazy hypoperfusion at the apices, but nothing, nothing that looks like a defect that would be secondary to pulmonary embolus. And here is a CT. Oops, that's the sagittal. Let me find where his. And these are always outside studies. Now, what's interesting here is a couple things. Let me just make this sharper. So, severe pulmonary hypertension, I think he underwent right heart cath. I think his, PA pressures are in the 70s, 80s, and a lot of these nodules. Now, unfortunately, we're not going to have path proof on this because he doesn't want to have transplant here. He's from Northern California. He may go up to UCSF to get a transplant or somewhere else. And you can see all of these nodules, and he's not an IV drug user. I made sure to ask them that. They flat out denies use of IV drugs. And so we're presuming that this is secondary to pulmonary capillary hemangiomatosis / PVOD. It doesn't look like those fuzzy-ish nodules you see with PAH. The other striking thing was the amount of lymphadenopathy he has. I know you can get secondary causes of PCH and especially PVOD occasionally with sarcoid. And I know you with PVOD, so I have a lot of cases of, I know they're one disease now and considered PCH / PVOD, but imaging wise, they do look a little bit different. And you have some cases that clearly look like PVOD and some that clearly look like PCH, at least on imaging. And the PVOD ones I see tend to have some pretty big nodes due to the fact that there's, it's basically fluid from impaired drainage, and you get this edematous looking nodes. This one just has really bulky nodes. So we were wondering if it was, could be sarcoid related, or he just has bulky nodes due to the PCH. So I looked at about 10 cases of PCH we have here, and I haven't seen nodes as big as this, but I don't know what other thoughts you guys have. Unfortunately, we're not going to get tissue on it, but
Was there any left heart dysfunction?
No.
No.
Left heart was completely normal.
And no edema, which would be unusual for this degree of PVOD, right? Without.
Yeah, exactly. So the PCH ones can have not a lot of septal thickening. I mean, you could say, oh, there's some mild septal thickening. I mean, it's really not bad. He has no effusions. Left heart's pumping good. But these biggish nodes.
I think this is a very mysterious case.
Yeah, it's not CTEPH. We were labeling, and it's some form of, I'm presuming, type 1, PAH. The only thing I asked them is to make sure that he doesn't have IV drug history, and they said that they asked him, and he adamantly denies it. And yeah. So unfortunately, I don't know. I don't think we'll ever get a definitive. I mean, we have a couple of cases of people who've undergone transplant here who do have PCH that do have nodules this extensive. But again, that's like one. Anyways, nice case of something.
Yeah. All right. Thanks.
Those are my cases.
Awesome. Thank you. Okay, Peter or Brian or David or Howard.
Correct.
Who is that?
I can go, Jeff. I have a few quick ones.
Okay. Did I just send it to the wrong person?
I got some message from GoToViewer, but I did not the typical one I get when you share the screen.
Here, let me make you an organizer and see if that helps. All right, I'll try this. I'll make myself the presenter and send it back.
Says GoToMeeting needs to use accessibility features. Open
Yeah, you'll have
system.
to say yes, and I think you'll have to log out and log back in. So someone else can
Okay.
come. We'll circle back around.
All right.
Anyone else?
I'm not sure if it'll work, but I can try.
Okay. You need to turn up your volume just a little bit there, Brian.
Sorry. Can you guys see my screen okay?
Not yet.
Okay. Yeah,
You have two connections. Do I need to send it to your computer connection?
Yeah, the computer
All right.
connection.
Oh, there we go. I see your screen now.
Excellent. So this is a 20-something-year-old with a previous history of aortic coarctation, now with abnormal conduction abnormality. Okay. Looks like you guys can see my screen now. Can you hear me okay?
Yes, see and hear just fine.
Excellent. So this is a 20-something-year-old with a previous history of aortic coarctation and now a conduction abnormality that they're calling Wolff-Parkinson-White. Also had a mechanical aortic valve. So this is his MRI from on the bottom left here from 4 years ago, and this is the most recent one. And you can see back then the ventricular wall is pretty thick, and there was some kind of excessive trabeculations. And then it got a little thinner over time, not a whole lot, still relatively thick. And there's now this area of chemical shift artifact, predominantly anteriorly. And then the delayed postgad was interesting. There's kind of this circumferential enhancement. I think it's real, subendocardial, involving the left ventricle. You can see it here also in the forechamber, kind of going a little bit more towards the mid chamber as well. I think David showed a similar case of this a few months ago, and I'm wondering if this could be papillary, sorry, not papillary, endocardial fibroelastosis. What do you guys think? Kid with a previous hypoplastic left heart repaired in infancy, now with subendocardial enhancements. I think David showed one with calcification. Travis had said that he saw some similar ones. Oh.
I'm going to defer to Seth on this one.
I think he may not have made it back.
Oh, no, I'm here. I was just kind of zoned out looking at another clinical case. You talking about subendocardial enhancement and hypoplastic heart?
Yeah, like hypoplastic left heart syndrome repaired in infancy. Wondering if this could be papillary, sorry, not papillary, endocardial fibroelastosis.
Yeah, I don't know. I would have to look it up. I mean, it would fit. I mean, the enhancement pattern would fit. I don't know if I've ever seen a case.
Okay. Yeah. Well, that's that one. Otherwise, still kind of a mystery, but yeah.
How is the function? Is the function relatively preserved?
Let me double check. I think no. See, LVEF was no 14%. Sorry. Well, this one we had a gating abnormality, so we couldn't get function very well. In the past, though, 4 years ago, EF was preserved. I think down a little bit since then, but probably not 14%.
And it's not, and he didn't undergo a transplant, because I've seen this with transplants with mycovascular disease. This is actually, was it a cardiac transplant, or was he underwent some other surgery?
He had let's see, he had a coarct repair, bicuspid valve with commissurotomy ×2, and then mechanical aortic valve. But yeah, no transplant.
But he wasn't he said he was a hypoplast left?
Sorry, I meant like in that spectrum with the coarct and the.
Oh, okay.
Yeah.
Yeah, I don't know. No, I would be guessing. I've seen this in post-transplant patients, but not anyone with that.
Okay, cool. So the next case, this is a follow-up from a few weeks ago. There's this enhancing mass. I think it's either invading from or arising from the RVOT. You can see we lose the right ventricular anterior wall here. Very avidly enhancing some central areas that are hypodense. Here's the RCA. It looks like it's separate, but I think there's some probably conal branches here, maybe from the LAD that are hypertrophied. The patient went on to get a PET. You can see here on the PET images, very hot. So it's a 16.7 SUV max and centrally photopenic, consistent with necrosis. Also had a MR. Unfortunately, patient couldn't tolerate the MR and left before we could get the delayed post-GADs. You can see here in the early post-GADs, very bright. Here's the T2 fat sets, fairly bright with some areas of low intensity. So I think based on this is a follow-up from last week, and we said it could be hemangioma given the degree of enhancement. I think the degree of FDG uptake makes that pretty unlikely. So I favor this to be either an angiosarc or a dedifferentiated paraganglioma.
Yeah, I would definitely get an MIBG study. Because this is probably, it looks like a paraganglioma. Or some really nasty vascular I've seen some high flow vascular malformations, but they're not going to be bright on PET. So it's but it's in a weird location for an angiosarc. Do you have a 4-chamber? I mean, it could be an angiosarc. It's just a strange location for one. How fast does it perfuse?
Yeah, let me pull that up.
Wow. So yeah, no, it could be an angiosarc given how fast it perfuses. I mean, it's literally just like the blood pool. Yeah. I mean, that's really impressive.
Yeah. I thought it could be possibly a dedifferentiated paraganglioma, but just the degree of FDG uptake, it was 16.7. You could see it's like as bright as the left ventricle.
Yeah.
So it'd be hard to believe something benign could do that. But yeah, they were collecting urine catecholamines, and I think those were negative so far. But
yeah, so then it's probably just going to be an angiosarc in a weird little bit of an atypical location. Do you have the axial to see where it's in relation to, or even a 4-chamber?
I don't have 4-chamber heart views. I mean an RVOT, but
yeah, no, you're right. It's probably an angiosarc, but it really does look.
Brian, did you say it was pretty fast growing, or did we not know how fast it was growing?
I don't really know. It's the radiograph didn't look a whole lot different. We've got a radiograph from 7 years ago, and that hasn't changed that much. But I'm not sure if this would be really radiographically apparent.
Yeah, I mean,
cross-sectional.
I mean, Castleman disease can be that bright on both perfusion and FDG, but that's just not a typical location for a node to give you Castleman disease. So I don't think that's likely. I mean, yeah.
And there's endocardial effusion. So
for me, the concerning thing was just that how it's interdigitating here between the MPA and the aorta. Like it kind of looked like it was probably arising from somewhere in there, like a claw sign. And then this last case, hopefully, is a little more straightforward.
Are they going to take that person to surgery?
I think so. Yeah, yeah. I'll recommend. I'd recommended a dotatate earlier, but they hadn't done it. But I think I'll call them again and tell them to do the MIBG. But even if that's positive, I think they probably should still take it out.
Yeah, no, it's
yeah, they asked me to biopsy it. I said no, thank you.
no, I wouldn't touch that.
This bottom left image is a comparison from 2 months ago. And this is someone on anticoagulation who came in with sudden abdominal pain. And what you can see here on the non-contrast in the top left, there's a ill-defined hyperdense blob overlying the infrarenal IVC. And then on the portal venous phase, you can see it's not enhancing. So I've never seen this before, but I thought it was likely going to be an IVC intramural hematoma. It doesn't look like there's any. Usually the retroperitoneal hematomas that I've seen have come from a muscle, but there's really no muscles there. The median arcuate ligaments above that level, and it doesn't look like it's coming from the wall of the duodenum. So yeah, I don't know if anyone's ever seen an IVC intramural hematoma.
No, I mean, is the wall, is it tough enough to hold a hematoma like that? I've not seen that.
Yeah, I don't know. Like you can see, here's the residual
Yeah,
IVC
for sure.
confine. I asked one of my IR colleagues, and he said he thought they probably do these all the time when they're doing angioplasties of the SVC and IVC. And then I found a case report of one from trauma, but this was a spontaneous event.
Interesting.
Those are my cases.
All right, thank you. All right, Peter, you want to try again?
Yeah, we can try.
All right.
I'm getting the same message about system preferences.
Okay, don't end the meeting.
Yeah, sure.
You have to go into the, if you're on a Mac, you have to go give it permission and then restart the app. But yeah, there was some update pushed. I had problems last week with it.
Okay.
I'll let you tinker with it. Just don't end the meeting.
Okay.
I'll go ahead and let's see. I'll go ahead and show my cases, and then I'll go ahead and show my screen here.
You let somebody else.
Yeah, I'll show. Okay. So this is a young guy who came in short of breath to emergency department. And you can see he's got this sort of bilateral hazy opacity, and it's very central peripheral sparing and sort of upper zone. So not a typical looking COVID or anything like that, but he admitted to actually had recently smoked cocaine. So I read that as crack or something like that. So good luck for pulmonary hemorrhage or some acute lung injury. And here's his chest CT. And you can see really nice, and I showed a case of pulmonary hemorrhage last week, but really nice sort of acinar type nodules or filling the whole lobule with sparing of just the periphery there. So you see the black lines around the vessels. So good look for pulmonary hemorrhage in the right setting. Even some suggestion it's sort of crazy paving-ish. So he got better just with supportive care, but this is a known complication of cocaine or crack. You can get it with both. But particularly smoking it as well, and produces pulmonary hemorrhage. It can also cause an acute lung injury as well, but he started getting better within 24 hours on imaging and with just supportive care, so fits with pulmonary hemorrhage. I guess you could get a non-cardiogenic edema too, because the cocaine can cause coronary vasospasm, but usually the troponins will bump. Okay.
I haven't seen a good crack case in a decade.
That's
awesome.
Yeah, I don't know if it's crack because it said cocaine, but who knows? I don't think you can smoke powdered cocaine. This is Go ahead.
They did check his troponin, right?
I believe it was normal. So this is a cool case. So this is a young guy, and I think if you have the key bit of history, you can make the diagnosis without further, it's confirmed, but it's an important relationship. So this guy comes in with chest pain, shortness of breath. You see he's got a big mass in his mediastinum. And he's got a bunch of lung nodules. Looks like some ugly kind of cancer, but he's a young guy. He's got sort of a funny looking torso, sort of a narrow chest. On his CT scan, he has quite fairly extensive gynecomastia for a young guy. I mean, who knows? We might see that. And this large mass here. And the history is he has a history of Klinefelter syndrome. And that's the XXY sex chromosome abnormality. So they're phenotypically male primarily, but they have actually something like 20% of malignant germ cell tumors occur in this population. And this is one of these big, ugly, malignant germ cell tumors with a primary prevascular, so big, hard to see where, mediastinal mass. And this one is metastasized to the lung. He also has these filling defects in the pulmonary arteries, which probably are tumor emboli, because this mass does invade one of the systemic veins. It's up here, I think, if I remember correctly. Yeah, it invades the subclavian or brachiocephalic vein, right? Subclavian vein right there. So I suspect these are tumor emboli, and he's got lung mets too. And they biopsy this, and it is a malignant germ cell tumor with yolk sac components. Very aggressive ones, but they do respond fairly well to chemotherapy. But that Klinefelter syndrome is pretty helpful. This is now the second time I've seen that, and with that information can pretty much suggest the diagnosis. Because typically in a younger patient, you would think of a thymic tumor, not sorry, thymic tumor, a lymphoma or something, but it just doesn't fit with the imaging. Okay. This is just a classic case. I came across this case because this patient's got a lung transplant, but this was an older radiograph, and you can see there's biapical thickening, some old trauma. But more importantly, I think you'll notice the hyla are really distorted. It almost looks like an old Hodgkin lymphoma mantle radiation appearance, but that's not the case. And you can see on the CT, this was a pre-transplant CT. There's all this thickening up in the apex, not as bad as one would think. For someone needing a transplant, but this is all pleuroparenchymal fibroelastosis. You see the bases are spared, and so marked upper lobe volume loss. And in my experience, they don't have a ton of visible stuff on imaging when they get really bad, but I think it's so rigid up there that the upper lobe's function is very diminished. Here's a coronal showing the thickening up in there. And that's just
how old was this guy?
He was young, I don't know, 30s something.
Yeah, it's funny. I had a case the other day, and you never know. It was like a 78-year-old woman, and it was raging. I mean, if you put it into a 40-year-old or 50-year-old or 30-year-old, you say, oh, it's really bad case of pleuroparenchymal fibroelastosis.
Right.
At what age do you, I mean, I was debating, I just said, I just called it prominent scarring. I didn't want to, it was an incidental finding. She was asymptomatic. It was a cancer screening thing.
Yeah.
To me, it's a disorder of aging, just like aging lung kind of thing. And sometimes it gets whack.
Right. Well, I mean, look how much volume loss he has. I think that's the clue.
Yeah.
I mean, these hyla are sky high, considering how little there is up there. So, and I can't remember the time frame. 2017. Yeah, this was before his transplant, but the radiograph and the CT are contemporaneous. So.
It's like, what age do you stop calling, you have an 85-year-old with fibrosis and you're going to call it a UIP pattern? It's just like I debate with that sometimes. You see.
Are they symptomatic? And if so, what are their PFTs?
Yeah, exactly.
All right. Okay. So, and then we got some time, so I'll show this case. This is kind of cool. So this is a case where the imaging is pretty boring, but the pathology is quite fascinating. So this is a patient who I think had an insulin detected lung nodule, fairly young patient, had a smoking history, and had this sort of cavitary nodule here in the left lower lobe. It has this funny atelectasis, almost looks like someone tried to radiate it, but that's not the case. But it looks like an early lung cancer. So this was actually resected as a lobectomy. And so here is the path. I gotta make my little thing go away here so I can see what I'm looking at. So there's the main tumor, and the big problem with this, the reason the path was reviewed, is you can see there's lymphovascular invasion. You can see all this tumor nest here, and again, we're up against the pleural surface there. It's a very ugly dedifferentiated tumor. It's primarily acinar type, but it did have a micropapillary component to it, and I think that these may be the little micropapillary areas right there. And then this was interesting. This is far away the main mass. So again, this was a 2-centimeter nodule at most. And this is in the lobectomy specimen. You can see all the normal lung, but then there's a nest of tumor right there, far away from it. Again, lymphovascular invasion. And then another one here, there was a separate, they called it a pleural-based, I'm going to take it a subpleural nodule with extensive surface involvement, so involving the pleura. You can see all these tumor cells invading into here. There's some right there, right up against the pleural surface, so small component. So this is important because it changes what looked like a stage 1 tumor to now a stage 4 tumor, right? We go to an M1A because there's pleural involvement. All the lymph nodes, interesting, were negative. They sampled all the ones in there and a complete margin. So the reason I show this case is this just shows how important the pathology can be, and when they look, and even if you go back, you can't see any of this stuff on the CT scan. So and then when you have an aggressive pathology like this is one of these acinar with a micropapillary. The micropapillary is associated with a very poor prognosis, regardless of the staging. So I suspect maybe this is contributing to it, but this is just a bad actor, and it greatly changes management from a definitive resection to now adjuvant therapy. But it was kind of cool to get to see the path on this otherwise innocuous looking early stage lung cancer. And there's nothing about it that tells you it's aggressive other than it's cavitary, and you can see these pleural tags, all signs that we typically associate with cancer. Okay, and then we got time, so I have 2 more cool cases. Let me show this one first. So this is a 59-year-old who has an ANCA-associated vasculitis. And I have 2 cases that go together. This is and has pulmonary fibrosis. And what's interesting about this case is how fast this fibrosis is progressing. So you can see there's some emphysema. I'm waiting for it to load the stack here so it gets a little bigger. Make it a little bigger. There we go. And you can see, so you got some fibrosis mixing with emphysema. It's very subpleural predominant. There are some more central bands. As we go further down, you can see it's clearly a basal predominant process, but it's not so exquisitely subpleural in the lower lobe. So this is hard to specifically give this pattern a name. It's definitely not a UIP pattern. It's way too much central disease, but it's a CTD, so they're often mixed or has some NSIP features. But that is the scan at the first scan I had. Now this one is done about a month later. And you can see, oh, actually, I got my dates backwards. I got my dates backwards. That was this is the initial one here. Sorry. So these are, I take it back. These are 11 months apart. So this was the baseline. And you can see this is fairly rapidly progressing, which is, we usually associate with myositis, particularly the anti-MDA5 antibody. So I think most institutions now, I know we do have what's called an extended myositis panel. So in patients who present with pulmonary fibrosis where we don't have a cause, as part of our workup for connective tissue disease, we do send off this extended myositis panel because those are associated with rapidly progressive fibrotic lung diseases. But this is an established, this is an ANCA-associated vasculitis, and there were no other autoimmune diseases, but they are associated with pulmonary fibrosis. But I don't think of it as this aggressive. There are some large nodules in there. I'm not sure what those related to at the time, but just kind of a rapid change just over the course of 11 months. So a really bad case, and those are those nodules. I don't know if those are some lymphoid aggregates or something else, something else related to it. And then this companion case here is a 68-year-old with Sjogren's syndrome who also has lung cancer. Let me get these dates right this time. Yeah, so this is the original one. So this is back in a year or so ago. And Sjogren's, we typically think about LIP, but they can also get lung fibrosis. It's often NSIP-like. I've seen UIP patterns. But at that time, not a lot of fibrosis. We see some basilar ground glass and some subpleural reticulation and some mildly dilated airways. There's a little effusion at that time. There's a pericardial effusion, all things to me that point towards connective tissue disease. So that was then, and then we jump ahead about 6 months, and we can see it's actually increased quite dramatically. A lot more traction bronchiectasis, much more ground glass. So very NSIP looking appearance, has some underlying heart disease as well. And now the most recent scan, that's this one here, we see just really dramatic increase and actually developed pneumomediastinum spontaneously and really severe lower lobe traction bronchiectasis. So becoming more and more symptomatic. And somewhere in here, he had a lung cancer too. I got to remember where that was as well, just on top of things, making matters worse. But 2 cases of rapidly progressing fibrosis. They're usually associated with connective tissue diseases, often myositis, but here's a case of a ANCA and a case of a Sjogren syndrome with that. And I think that is all I have today. All right, David, or Peter, if Peter's thing is working again.
Jeff, it said I had to restart my GoToMeeting, but I have a share screen button here I can hit and see if that'll.
All right, we'll try it.
Well, it says restart, so I don't want to log everybody out.
All right, we'll try you last. David, do you have any cases?
No.
All right, well, Peter, then you can give it a shot because you're the last one.
If I have a couple.
Oh, sorry, Howard. Totally missed you there. We'll let Howard go, and then we'll try Peter.
Yeah.
Sorry about that.
That's fine. Okay, this is a abdominal CT back in 2009. I don't know that this was seen at the time, or perhaps if it was, it wasn't accorded much importance. But just for comparison, this is what the lesion looks like in 2009. So it's got smooth margins. It is clearly a pleural-based lesion, homogeneously attenuating and small. Now let's go forward 10 years, and we'll see, again, this is an abdominal CT, that it is increased in size, but not dramatically so. It still has the same morphology and the same appearance. Perhaps there's a little bit of enhancement within, but otherwise very consistent with a slowly growing tumor, pleural-based. And there's a differential diagnosis for that, but I would suspect that most of us would probably pick a solitary fibrous tumor of pleura as the most likely diagnosis. And this was removed, and that's exactly what it is. So it is a fibrous tumor, and typically now the pathologist will stain this for STAT6, which is the preferred, I forget what it stands for now. And typically they're positive quite readily for STAT6, solitary fibrous tumors. Here is another nodule. This one was discovered in the context of MRI, and I can't remember why the MRI was done, but there was a nodule here in the left upper lobe. And a little while later, CT was done for further eval, and here it is. Small, smooth margins, no calcification within. And of course, there's a differential diagnosis for that. So we think of probably most likely things like carcinoid hematoma, particularly if there was any fat or calcium in. And then beyond that, there's the differential diagnosis of other causes of nodules. Certainly in the young person, and particularly in the pediatric age group, the differential diagnosis for a nodule is an inflammatory pseudotumor of lung, and there are lots of names for that. I think in childhood, often they're plasma cell rich, so they may be called plasma cell granuloma. But beyond that, pseudotumor of lung is a really good thought. And this one is indeed that, but it's this particular form of it, and it's the inflammatory myofibroblastic tumor. And some of them, but not all, typically are ALK positive. So this one is one in which fresh demonstrated ALK rearrangement. But otherwise, based on the pathology, pathologists will typically think about that. You can see they'll stain them for a whole bunch of things. But ultimately, they may also look for ALK rearrangement. So this is effectively a clonal neoplasm. If you have one that's aggressive, particularly one that's metastasized, of course, and it does have the ALK rearrangement, those patients will be treated with crizotinib by virtue of this particular mutational abnormality. So an IMT, and they can vary from a small nodule like this to, and we've shown now in this webinar before, very large ones in young people. This next one is just a curiosity. The chest radiograph I'll go right by because we will not see this. And one could readily go by this as well. So this will be the differential diagnosis for a small nodule, well circumscribed in the trachea. And in this person, he does have a malignancy. It is a clear cell carcinoma of kidney. And that's what this is. So it's a solitary metastasis. They took that out, and the patient has done quite well. So metastatic tracheal clear cell carcinoma of kidney. This one is really interesting in terms of the pathology and trying to fit this into a box. It's another case of interstitial lung disease. Let me bring up the thin cuts here, and then I'll give you some context. So I did this on Twitter, so you'll see on the left-hand side the summary. So he's a male. Well, let's just scroll through this first and see subpleural reticulation, relatively low perfusion. As we go down, the perfusion of the reticular opacities is increasing. As we get lower down yet, we see some foci of non-subpleural traction bronchiectasis, like here, consistent with fibrosis. We see areas of lobular hypoattenuation, and there is an expiration series that shows that that is some air trapping. And then when we get all the way down, there really is a dearth of anything to suggest subpleural traction bronchiolectasis or honeycombing, certainly not honeycombing, and maybe very sparse subpleural traction bronchiolectasis. But certainly down here, with looking at these lungs down here, one wouldn't think of UIP. So there is the clinical information. There were no clues there as to what this is, and particularly it doesn't have a connective tissue disorder. And I'll just make this big. In my report, I would, at least with respect to UIP of IPF, I would choose the box that says CT indeterminate for UIP. So let's just go on now to, if I can make it advance here. The path findings, I'll make this big. So there were findings here that, first on the left-hand side, findings that certainly make a pathologist, sorry about that, think of UIP when there is a spatially very heterogeneous distribution of fibrosis with relatively normal lung in close proximity. And of course, at the boundary between the fibrosis, the pink, and normal lung or cystic spaces, I look for fibroblast foci. And this person, I'm not showing you that, just had very few of them. Away from that area, there's some areas in relation to small airways, bronchovascular bundles, in which there is lymphoid hyperplasia, lymphoid follicles, but relatively few of them. And then in areas like this, where the interalveolar septa are not quite normal, there is thickening of those interlobular septa with cells, NSIP-like. So this has a mixture of things. Certainly in UIP, one can sometimes see about small airways, lymphoid hyperplasia, but it shouldn't be more than just a little. And similarly, one can sometimes see under the microscope foci of NSIP, like thickening of alveolar septa, but that of course should not be the dominant finding. So overall, sometimes it's really hard to classify this. I think this is going to be a non-classifiable under the microscope fibrosing lung disorder. If we saw lots of this, they would think of connective tissue disease, as I said, but he doesn't have a connective tissue disorder. So if you want to read about how pathologists think about and try to make distinctions between these different things, it would be this article. And the other thing that I didn't mention is that in terms of chronic hypersensitivity pneumonitis, pathologists like to look for airway-centric pathology. They want to look for bronchiolar metaplasia, which this person does not have. They look for giant cells, bronchocentric disease, which this person does not have. So we really have to settle sometimes for a non-classifiable interstitial fibrosing disorder, perhaps in a patient like this. And I'm sure that pathologists will be inter-observer variation in how these kinds of cases are reported. Jeff, any comments about that overall?
No, that's a nice example with the correlation. I don't know, when I see, I mean, I'm not a pathologist, but when I see kind of lymphoidy stuff in the lungs, I really think about connective tissue diseases or multiple mixed patterns. And then one thing our pathologists have always talked about is when you see multi-compartmental involvement. I mean, we talk about on CT, but also on pathology. If they see any pleural involvement or more than just our airway or vasculature, but yeah, I suspect a lot of these cases are these non-classifiable ones. If they're not HP, they end up being CTDs that just haven't declared themselves yet.
Yep.
Because
time will tell. It's a treatment dilemma. He doesn't have any previous CT comparison. He doesn't have a history that's helpful.
Yeah.
So sometimes,
although I guess treatment's gotten a little easier because of the two anti-fibrotics, and one of them is approved for at least Sjogren's syndrome, and one of them is approved also for, I think, non-UIP fibrosing lung diseases. Typically, if they have more than 10% of involvement, and sometimes I know some pulmonologists will do a BAL looking for a lymphocytosis to maybe consider doing anti-lymphocytic therapy over anti-fibrotic. And we found even good pulmonologists with a lot of experience in ILD, we often will send them to rheumatologists. They do like as a capillary something in the nail beds with lights. I can't remember all that, but very subtle things they can do sometimes to pick up things. And there's a whole panel of labs.
And try to evaluate.
Yeah, I like those path images. Those are nice.
Yeah, they Body's panel for antibodies for connective tissue disease are negative. So clinically, at least based on what I've read, he doesn't have a connective tissue disorder. So they're a little bit stuck. Time will tell. Yeah. Okay, those are my cases, Jeff.
All right, thank you, Howard. All right, Peter, you want to give it a go?
Sure, we can. I'm back on. Jeff?
Yeah, I see you. I hear you. I don't see you.
Oh, screen share option, or do I have to activate it from my end?
I made you the presenter. I can let me make myself. Let me make myself the presenter, and then I'll make you the presenter again. It should get the little pop up. Any luck?
No.
All right.
I guess I'll
sort it out next time. Yeah. Sometimes there's something weird. I had that same problem. Actually, there's two of you. Let me try this one.
Must have been an update or something. Okay, now I see it.
Yeah, there's two of you. That's what happened. I was sending it to the wrong one. Good. Yay. Okay. All right, we're good.
I'll just show 3 quick ones. And this is a case. History isn't that relevant here. Just a quick show and tell. But this patient underwent cardiac cath, and this was shortly after. And I'd never seen this before, but there's obviously a big hematoma here in the right abdominal wall on the right side, and then there's a pseudoaneurysm that's actually coming off of the right inferior epigastric. So I've seen plenty of pseudoaneurysms off of the common femoral, but I've never seen one off of the inferior epigastric. And this was easily treated with percutaneous thrombin injection. But I presume they must have just accidentally cannulated the inferior epigastric as they were going into the external iliac there. Okay. This is a young patient who is 26 years old, and in January of this year, they had a mechanical aortic valve replacement at an outside place for aortic insufficiency. And just after the surgery, they just didn't feel good. Multiple palpitation, not extremely sick, but just general not feeling well, exhaustion, multiple palpitations, and then came into our institution a few weeks ago, and there was concern for perivalvular leak, and so this is the CT that I read, and you can see as we go to the aortic root, there are multiple abnormalities here. They did do blood cultures, and those were all negative. I don't think he had a white count when he came in, but I was very concerned about an infection here of the aortic root, and called these abscess cavities. And then you can just see all this soft tissue that's growing around here. So it's basically abscess phlegmon and with abscess cavities. And the biggest one, so this is the RCA right here in the front. And as we go inferior to the RCA, you can see this outpouching just drooping down. And actually, there was pretty good preservation of the annulus. So the valve prosthesis was well opposed to the annulus, but you just have these abscess cavities. And here was, unfortunately, I didn't get pictures, intraoperative pictures, but I have I can share the surgical report. So under the right coronary ospia, there's a large abscess cavity. Button was extremely difficult to mobilize, but they were successful. So this is a good example of abscess cavities in an infected aortic root. And last case is just another kind of not that uncommon, relatively common, just quick example of a transeptal course of an anomalous left main. So the left main's coming off of the RCA, and as I'm going down, you can see it kind of takes a downward course, and then it goes into the interventricular septum and then comes out there. I did a reconstruction of it, and this is the image that is good to show. This was actually published. It's been published, I think, more than once, but there was a JTR article. This is called the hammock sign. So this downward inflection of the left main here as it gets into the septum is kind of a sign for a transeptal course. So I thought that was a pretty good example of that. That's it.
Yeah, thanks. That's a really nice example. Thanks for
sharing that.
Okay, well, good. We got that all in. Thanks everybody for their patience with the technology. Yeah.
Thanks, everyone.
All right. Take care. We'll talk to you next week.
Thank you.